This patient had an excellent response to chemotherapy. Her tumor was able to get to no evidence of disease again based on the CA-125 level and imaging. Certainly this is what we would hope for and expect, especially in a germline mutant population. Those patients tend to respond, or their tumors tend to respond very well to chemotherapy, and we're often able to get them to a complete response again. So she was right in line with what we would hope. The problem, as we mentioned, even in the upfront setting, and this is the same in the recurrent setting, the problem is these patients will often recur. And that's really been the rationale for adding maintenance therapy. And specifically in a patient population that has a germline BRCA mutation, the strategy of utilizing PARP inhibition has been very favorable over the last few years. So for this particular patient, she was offered Rucaparib on clinical trial. This clinical trial has been reported, Ariel 3. Her response was about 2 years, disease-free survival. That's about average. I think that the actual trial was more like 17 to 18 months, but certainly within the range of what we would expect. And she certainly had quite a bit of benefit from the use of PARP inhibition in this setting. This particular patient had a very common adverse event that we see with the treatment of Rucaparib, which is a transient elevation in her transaminases. She had an elevation in both ALT as well as AST. Initially, when we were managing these patients, we would stop the drug, we would hold, we would let things resolve, and then restart. But what we learned both in the Ariel 2 and Ariel 3 studies is that this often will be a transient elevation that'll go away on its own without interrupting the drug. So you can really, you want to be safe and make sure there's no evidence of hepatitis or inflammation of or damage to the liver. So you watch that total bilirubin. You can use something called Hy's Law, not to get too technical, but make sure the patient doesn't qualify based on that law, and you can treat through. So you just want to keep an eye on them. You want to check them maybe every couple of weeks. Make sure you're not seeing continued elevation, but the majority of these patients can stay on the same dose level and don't even need to be dose reduced. Sometimes if you do see some elevation, that transient elevation is continuing, you can do a dose reduction to just try to get that trend to go in the opposite direction. Rucaparib generally has been extremely well tolerated for the majority of patients that have utilized it for treatment. We talked about the elevation in transaminitis or transaminases. We can also see transient elevation in creatinine, but generally this is not associated with renal failure or renal disease. And again, you can calculate a GFR, make sure that the kidneys are functioning well, and treat right through. This is not something that requires a dose interruption or even a dose reduction. In addition, there are cross-PARP adverse events that we see. There's certain class effects. Things like nausea, GI distress, those types of things can be seen early on. But with early management, kind of aggressive management, making sure the patient knows that these things can happen, you can get those to go away quite quickly. Things you can do are, prophylactic antiemetics, starting, giving them a nausea medicine antiemetic 30 minutes to an hour before the drug, maybe even putting a little food on their stomach to allow for them not to take it on a completely empty stomach. Those types of things can really mitigate the nausea and some of the reflux and those types of things, which can be very disturbing to patients. Other things like diarrhea, constipation, not been as common. Generally what we see is the first few months on therapy are where we kind of see the majority of the adverse events. Once you can mitigate those and manage those, patients can remain on these drugs for extended period of time, like our patient here for 2 years, with very few continued adverse events. When you have a patient with platinum-sensitive recurrence, especially one that has a known germline or somatic BRCA mutation, it really makes sense to use these types of precision medicine strategies. We now have a number of PARP inhibitors that are available at our fingertips that have been clearly demonstrated to improve our progression-free or our progression-free survival by some 15, 16, 17, 18 months. So that is a really impressive number that we haven't previously seen in the setting of platinum-sensitive recurrence. Now, certainly we all worry when we start using new agents, and targeted therapies like PARP inhibitors can have different side effects than what we're used to or what we've seen in the past with chemotherapy. But all you have to do is read your label and learn what to expect, help educate your patients, make sure they know just because it's a pill doesn't mean there are no side effects, and make sure you mitigate those side effects early, and these patients can stay on with a really long potential clinical benefit.